Greetings. This lecture is on falls, specifically on non-intentional falls in the elderly and children in non-occupational settings. The material to be covered in today's lecture will start with the epidemiology of fall injuries in the elderly and in children. There will be discussion of the types of injuries that most are commonly seen from falls in non-occupational settings, and then there will be discussions of preventive strategies to keep falls from occurring. The two groups most likely to be affected by unintentional fall injuries and deaths are children and the elderly. And when you think about it, that probably makes sense, because those are two stages of life where body control to prevent falls is maybe not fully established in the case of children, or it's starting to go away in the case of people who are elderly. I mentioned in the occupational injuries lecture that falls greater than 6 feet are not permitted to occur on construction sites. You're supposed to be protected from falls of greater than 4 feet in general industry sites, meaning non-construction work sites. We know from some of the data discussed earlier in the semester that when a person falls greater than 15 feet or 3 times their height, that's generally considered to be a significant fall, a very dangerous fall, a very often fatal fall. There is a lot of energy exchange that occurs whenever somebody falls from any significant height, and a massive absorbed energy upon impact, which is very similar to being in a vehicle crash. Data shows us, though, that even shorter falls, such as off of a 3-foot bed onto the floor, can generate injurious and at times deadly force. I'm going to talk to you about this article that you see here from Bowers and colleagues in the Journal of Rehabilitation Nursing. They set up some scenarios where they had a weighted dummy that they dropped at different heights off of a bed in order to see what kinds of forces were generated depending on the surface that the dummy landed on, and also about whether the dummy landed head first or feet first, because it was a whole body dummy. What they found was if you fall off of a 3-foot bed onto a tile floor and you fall head first, the force that is exerted against the head is over 4,800 newtons, or over 1,000 pounds of force. That's more than enough force to cause a deadly injury. Let's examine some of the unintentional fall, death, and hospitalization cost data from a recent year. This is from the CDC WSCARS system. If we look at deaths, first of all, we'll see that in this year, I think it was 2015 if I'm not mistaken, there were 26,009 deaths from unintentional falls. Roughly divided halfway between females and males. There was a few more in males. And if you look at the total cost was $7.2 billion. That's just from the unintentional fall deaths. If we look at unintentional falls that resulted in inpatient hospitalization, and therefore probably also resulted in rehabilitation, maybe some lost time away from work, if it was a workplace-related fall, or even if it wasn't, if it was just a fall that didn't occur on the job, it would affect somebody's ability to go to their job. That's also considered a cost as well. So if you look at the types of costs associated with hospitalization from unintentional injury falls, you'll see that, again, we're talking about almost 1 million people, 992,000 people in this year. You see the average medical costs, the average work loss costs for each one of those hospitalizations, and the average combined cost, almost $96,000 for each one of those cases, and a total cost of almost $95 billion. And then once again, you can break this down in female and male. There were more females hospitalized for unintentional injury falls. There's a demographic reason why you tend to see more females having unintentional injury falls than males. We'll go over that shortly. What causes people to be killed or severely injured when they have a fall is often head and brain injuries. These can include bruising, where you get pressure on the brain from blood leaking and then swelling, which then, as it puts pressure on the brain, can cause a brain injury. You can also get brain tissue lacerations when the skull breaks, and skull fragments will press into the brain. That's a very common form of head injury during severe falls. It's often fatal, and if it's not fatal, it's often debilitating. The person's quality of life is often not as good as it was before after that such a traumatic brain injury. In elderly persons, sometimes hematomas, those subdural bleeds, will often go unnoticed because the patient doesn't feel all the pressure inside their skull, because the blood will initially have space to go because some of the tissue in the skull, inside the skull, has shrunken with age, and so there's actually little pockets where the blood can accumulate. So hematomas sometimes go unnoticed for a little while. They're not immediately treated in the elderly. There can be complications that can result in death. One example from a fall, and it's not a head and brain injury, but when somebody that's older and breaks a rib, it's painful to breathe, so they don't breathe as deeply because of the pain, and they can then develop pneumonia. That's an example of a secondary complication from fall injury. Children, when they fall, they're more likely to actually have their head and brain impacted because children's physiology is different, especially small children. You see the little diagram on the right where if an infant or a toddler child was the same size as an adult, their head would be proportionately a lot larger. That's just the physiology of human children. And so children are top heavy. So it's easier for them to fall over. It's easier for them to fall head first. They don't always have the same instinct that adults or older children have to sort of put their arms down and brace themselves. So very young children are quite susceptible to head injuries if they have any kind of fall event. Let's look first at the data from falls in older persons here in the United States. We went over some of this data back in week 2. One of the leading cause of death, unintentional injury death, in persons over the age of 65 in the U.S. is unintentional falls. And it's not even close. It's by a large margin the leading cause of injury death. There's one fall that occurs every second of every day. Not all of those are fatal, but a lot of them can cause very serious injuries. 65 and over is the only category where falls are even among the top 2 or 3 sources of unintentional injury death. For most other age groups, it's unintentional poisoning, such as overdoses, or it's unintentional motor vehicle traffic incidents, or unintentional suffocation or drowning in the cases of infants and very young children. But at age 65 plus, it's falls, and nothing else is even close. It's estimated that more than 1 out of every 4 persons over the age of 65 and older falls every year. About half of them don't tell their doctor. They, either themselves or with some help, pull themselves back up. They sort of try to heal up from the bruises and some other things that occur, and they never report it. 1 out of every 5 falls causes a serious injury, such as a head injury or a hip fracture. And once a person over 65 gets a hip fracture, that's generally doesn't bode very well for their health for the rest of their lives. Those are not easy to recover from. A lot of data is missing, of course, because things don't go fully reported, but the current best estimate is that about 1/2 to 2/3 of all falls in people aged 65 and up occur in the home setting. The risk factors for falls in older persons include the following. Changes in vision. Certainly, as your vision deteriorates with age, it's harder to see obstacles that might be at your feet. Changes in gait and balance and other vestibular issues often make it harder to keep your balance, and if you lose your balance, that's an easy way to end up falling. There are changes in the musculoskeletal system as we get older, particularly when it comes to our strength levels in our lower body. We have the muscles of the legs which can start to atrophy a little bit. We also get tendons and ligaments that calcify and become a little bit more brittle, so that they're not as pliant as they once were, and they don't heal up as quickly either after a fall event. People aged 65 and up tend to have higher rates of medicine usage as well, and certain types of medicines such as tranquilizers, sedatives, antidepressants, and even blood thinners, which can cause dizziness, can all be related to increased risk of falls in the elderly. Fear of falling is another important risk factor. If a person falls once, it doubles their chances of falling again. This data comes from the Adult Falls section of the CDC webpage, shown here. There is a profound and noticeable gender difference in fall injury data here in the United States. If we look at data among those who were treated in emergency departments in the U.S. that are age 65 plus, we find, and this is from the Stevens and Sogolau study, whose reference is at the bottom of this slide, that women had a higher rate for all injuries, but that fractures they had a 2.2 times higher rate for fractures compared to men, and were hospitalized for fractures at a 2.3 times higher rate than for men. Total rate of hospitalization following a fall injury were 1.8 times for women compared to men. I mean, this is taking all types of factors into account, such as soft tissue injuries and things that aren't necessarily fractures, but that were part of the injuries that resulted from a fall. Even when we're talking about subjects who are age 65 and older, it's found that most of them, about 4 in 5, are treated in the emergency department and then released. Maybe with a prescription, maybe with some instructions on how to differently configure their home. Only 1 in 5 people age 65 plus who are admitted for a fall-related injury wind up having to be hospitalized inpatient. We do know that rates rise as people get older. Once you reach age 85, your risk of being hospitalized or killed from a fall are basically 4 to 5 times higher than when you're at the ages considered young old, meaning ages 65 to 74. It was found that the rates for both men and women for all injury diagnoses doubled with each decade of age. In other words, the rates of injury at age 75 were double those of age 65. The rates at age 85 were double those at age 75. And of course, it should almost go without saying, the reason why you tend to get more females in this data than males is because in almost every single age cohort in the U.S., women tend to live longer than men, and therefore they're more likely to reach an age where they are exposed to the greater risk of fall hazards that comes with reaching age 65, 75, 85, 95, even up into 3-digit ages. It's just, you're a lot more statistically likely to reach those ages and be susceptible to those injuries if you are female. Plus, there's also the effect of osteoporosis and other conditions that can make your bones brittle as you age, that are a little bit more prevalent in females. It will probably not surprise you to know that the number of elderly fall injuries that occur in the U.S. every year increases just about every year. There are a lot of demographic factors happening where the population of the U.S. is aging. So therefore, the cohort is getting older and therefore is more susceptible. What might surprise you is that if you look at age-adjusted rates, so we're not taking into account the aging of the population overall, if you look from year to year, from like roughly 2000 to 2014, that the age-adjusted rates for both non-fatal and fatal falls are also trending upward. And again, these are age-adjusted rates, so this has nothing to do with the aging of the population. There's just more of these events happening per 100,000. And so you might wonder, why is that? We're still trying to figure that out, honestly. There's a lot of epidemiology that's going into trying to figure out why, but there's been some theories proposed that I think are at least somewhat plausible. One is that the 65 plus population every year gets slightly less healthy just because Americans have been kind of in a poor overall health trajectory for the last several years as a result of chronic conditions, obesity, diabetes, some of the some of the other factors that being public health students you're probably well aware of. There's a higher use of medications now among the elderly than there was in previous years. As we talked about before, certain types of medications might make you a little bit more likely to have a fall injury. There's a lot more focus now on people sort of aging at home, and that is a good thing to do if you can do it safely, to actually be able to stay in your own home have some autonomy. There's not as much of a push as there might have been in previous years to get elderly relatives to accept assisted living or skilled care facilities. But that does mean that the rates of these fall injuries are always greater in people that are staying in their homes versus people that are in assisted living or skilled care facilities. And it also might just be better reporting that more fall injuries and incidents are actually being reported and recorded now. People sometimes, due to pride or other reasons, would keep this to themselves. So maybe it's just a matter of better reporting. But the age-adjusted rates are not trending in a very good direction, as you can see here. I mentioned earlier that hip fractures are a very common injury that occurs in people over age 65 when they have a fall incident, and that it's a lot more frequent among people who are born female. Let's dig into that a little bit deeper now. More than 95% of hip fractures are caused by a fall, usually by falling sideways. When people fall sideways, they tend to fall on their hip, and this can often result in a fracture, especially once you reach after age 65. The rate is 2 to 3 times higher of hip fractures in women compared to men after a fall incident. There's hormonal reasons for this, but mostly osteoporosis is a very common condition in postmenopausal women. And in fact, postmenopausal white women are at an even more increased risk. It's estimated that 1 out of every 6 postmenopausal white women will likely suffer a hip fracture in their lifetime. Hip fractures are another condition where the older you get, the greater your risk becomes for it, so that once you reach age 85 plus, you're at a 10 to 15 times greater risk of suffering a hip fracture after a fall than you would be at, say, ages 60 to 65. Again, the hip bone just becomes more and more fragile with age. Height is another risk factor. For women who are 5 feet 8 inches or taller, they have roughly twice the risk of those who are 5 foot 2 or shorter. And again, this just has to do with momentum during especially a sideways fall related incident. Once you reach an elderly age and have a hip fracture, only about 25% of people in this age group who have a hip fracture make a full recovery. About 40% of those with hip fractures require a nursing home or other types of skilled care following the fracture. About 50% will need a cane or a walker for many months and years to go, and possibly for the rest of their lives. I said before that hip fractures tended to be a pretty bad harbinger for the quality of life for the rest of life. The current estimate is that though anyone over age 50 that has a hip fracture, about 24% of them will die within 12 months of suffering that hip fracture. Again, the death won't be due to the hip fracture. It'll just be because the hip fracture is sort of a indicator of some underlying fragilities that impact quality of life and length of life. So when we're talking about those age 65 and above, as we said before, there are more fatal falls and more fall injuries among women than there are among men. But if we look at the entire lifespan, we see that men have a much higher rate of fatal falls, 11.54 per 100,000 versus 7.63 compared to women, whereas women have more non-fatal fall events. A lot of the fatal fall events in men tend to be because possibly greater risk-taking activities, certainly working the employment in more dangerous occupations such as construction, overwhelmingly skews more toward male gender, and this means that throughout the entire course of lifetime, men have a higher risk of fatal falls though once you get to age 65 plus, it's women that have the higher risk. Certainly, acute and chronic conditions can contribute to fall risk. Regardless of age, if you have vision problems or balance problems, those contribute to fall risk, and those can happen at various different times in life, not just at 65 plus. One thing that does tend to happen as we get older is the way we metabolize drugs changes, which is why some elderly people might be at greater risk of falls if they're on blood pressure medication or antidepressants or painkillers or many other things. The physical environment can also be a risk factor. As people get older, they have to, anytime you're getting on like a low-seated chair or something like a toilet, if it doesn't have grab bars like the ones you see here, putting yourself down on that and trying to get yourself up from that, this can be a great danger from falls. Poor lighting is another issue, especially as we get older and our vision is not as good as it used to be. If we can't see obstacles and hazards in front of us because of poor lighting, it increases the fall risk. As do throw rugs, which can very easily get knotted up and create a trip hazard. And also pets. Pets do greatly contribute to quality of life, but in some cases, if you have a pet that's not particularly well trained in how to be around somebody with balance issues or somebody who's older, if pets congregate at people's feet and they can't see them and trip over them, this is how a lot of fall incidents occur. It's a sad truth because we know some of the public health benefits that occur, particularly among people prone to loneliness, to have a pet, but pets can also be a risk factor for falls. So now let's talk about the two fall injury related articles that you were assigned to read this week. We'll start with the Verna and colleagues article. This is a good example of using data from WSCARS and also the National Health Interview Survey in order to address a topic of interest and sort of see what the data says, and if you find something interesting, you can write a paper about it. In this case, Verna and colleagues used this data to estimate the number and the cost of falls in the community-dwelling U.S. population. In this case, the phrase community-dwelling means a population that are unrelated who live together in an abode, such as an assisted living facility. So in general, when we talk about community-dwelling populations, we're talking about elderly, but it can also be people that live in group homes with people who have certain levels of developmental disability or many other conditions where they live in this sort of settings. So that's the population we're talking about. And what Verna and colleagues found was that almost 12% of this community-dwelling population had fallen in the past 12 months. And what was very interesting is that, of course, this when we divide this up, the number is highest in those aged 65 plus. In that case, 16.4% of the community-dwelling population over the age of 65 had fallen. But interestingly enough, there was also relatively high rates among the 18 to 44 community-dwelling population, 10.6%, and 45 to 64, where it was 11.4%. What they did determine was that, again, a relatively high rate of falls occurring in these community-dwelling populations. What they found was that it did go up with age, though. As we age-adjusted, it was found that fall-related injuries increased roughly 4% per year among older women from 2004 to 2013. And again, this is age-adjusted. Why has this occurred? Have to go back to some of the theories we talked about before that maybe has to do with medications, just poor overall health of the cohort, better reporting. We're honestly not exactly sure, but age-adjusted fall-related injuries increased 4% every year from 2004 to 2013, and that is of concern. And the total lifetime cost of annual unintentional fall-related injuries, we're talking about the cost of fatalities and inpatient hospitalizations and emergency department visits, in the year 2010 was estimated to be $111 billion. Now we'll move on to the study from Keel and colleagues in 2015. This was a cluster randomized controlled trial that occurred in New Zealand called the Home Injury Prevention Intervention, or HIPI. In order to be enrolled in this study, you had to live in a home that was built before 1980. So they were kind of wanted to sort of see what was happening in some of these older homes and what could be done to sort of improve outcomes of people that lived in these many decades old homes in New Zealand. So again, it was a cluster randomized controlled trial. The treatment group got some low-cost home modifications done to their pre-1980 homes. These would be things such as handrails and minor repairs for outside steps and internal stairs, repairs to window latches, installing grab rails for bathrooms and toilets, improvements to outside lighting so people can see a little bit better when they're coming in and going out, high visibility and slip-resistant edging for outside steps, repaired the lifted edges of carpets and mats, installation of non-slip bath mats, and slip-resistant surfacing for outside surfaces such as decks. Again, these were all relatively low cost. If you had every one of these put onto a house here in the U.S., it probably would cost maybe less than $1,000. So we're talking about relatively low-cost home modifications within the treatment group. When the treatment group was compared to the control group, it was found that there was a 26% reduction in the rate of injuries caused by falls at home per year exposed to the intervention. In other words, every year that people were in the intervention, there was a 26% reduction in the rate of injuries compared to the control group. So this effect from these relatively minor improvements that were done to these pre-1980 homes was statistically significant. Again, the relative rate in the treatment group versus the control group was 0.74 of fall-related injuries. If you look at the 95% confidence interval, you see that it does not cross 1. So therefore, this is a statistically significant reduction in hazard. This was found after adjusting for age, previous falls, gender, and ethnic origin. So it doesn't cost a lot to make a significant improvement in the quality of life and reduce the risk of fall-related injuries in people who are living in non-institutional settings, who are trying to sort of live out their golden years in their own home. Some prevention strategies for falls in the elderly include the following. First of all, there can be muscle strengthening and balance exercises so that as we get older, we don't lose as much of we don't have as much atrophy of our muscles, and we keep our balance a little bit longer. There can be a regular review of medications because, again, as we get older, the way we metabolize medicines, the way we respond to medicines can change. So the prescription that didn't make you dizzy last year might make you dizzy this year. So they need to be reviewed regularly with your physician. Regular visits with a physician for acute and chronic conditions, rather than self-medicating them or sort of letting parts of your life be taken from you, as often happens, sad to say. That would help a lot. Having supplements of calcium and vitamin D, particularly earlier in life, can sort of it can't completely prevent osteoporosis, but it can slow it down. And the more you can slow osteoporosis, the less likely you are to suffer a hip fracture or any other kind of bone fracture following a fall event. Certainly grab bars and adequate lighting and slip-resistant surfaces. We could stop a lot of falls from occurring if homes were all designed with these. Now, anytime you go to a skilled care facility, or a lot of for example, they will have all these. Everything will be on one level. There won't be any stairs. There'll be grab bars, adequate lighting, slip-resistant surfaces. But because a lot of people are aging at home now, these might need to be retrofitted into existing homes. Daily contact with family and friends is one of the most important things of prevention. It helps people to live longer and healthier, and there's all sorts of public health benefits from this, but it actually has been shown to reduce the fall incidence as well. And I really think that changes to the wider culture, particularly here in the U.S., need to be considered as well. Many of us, certainly, individually, we love and care for the seniors we know in our life, but our greater culture doesn't value seniors the way that it honestly should. Once people retire and are no longer participating in the capitalist system, there tends to be kind of a tendency to want to marginalize them. And that's just something that both individually and collectively we need to talk about how to maybe improve our wider culture and make it a little bit more of a friendly place for senior Americans. Now let's shift our attention to falls in children. Falls are the leading cause of non-fatal injuries in children from age 0 to 9 years. And if you look at sort of children and young adults aged 10 to 24 years, falls are a very close second. Over 3 million children require emergency department visits for falls in a given year. The most common form of falls are falls from an object. For children under 2 years old, this would be a fall from furniture. Off of a bed, off of a chair, off of something that they're balanced on. For children 5 to 12 years old, the most common falls that result in injuries and emergency department visits and possibly hospitalization are falls from playground equipment. Because this happens so much in children aged 5 to 12, there are some states that have mandated that the Consumer Product Safety Commission's public playground safety guidelines be met. And I'll show you some examples of some playgrounds that meet those guidelines in just a second. One of the big requirements from the public playground safety guidelines is that public playgrounds shouldn't be built on asphalt like they used to be when I was a kid. There should be two options available for surface of public playgrounds: unitary shock absorbent materials or loose fill materials. Playgrounds should never be installed without protective surfacing of some type. Concrete, asphalt, or other hard surfaces should never be directly under playground equipment. Grass and dirt are a little bit softer than concrete and asphalt, but they're still not considered protective surfaces because wear and compacting and other environmental factors can eventually reduce their shock-absorbing effectiveness. And carpeting and mats are generally not good enough unless they're tested to and comply with ASTM F1292. Loose fill materials should be avoided for playgrounds that are intended for toddlers. I think you can kind of understand the obvious reason why you want to avoid that, because toddlers put everything in their mouths. And if you do not want a toddler to be consuming rubber mulch or even wooden mulch or any other loose fill materials, even though for older children those make great materials for softening the landing off of playground equipment. Many states and cities and municipalities have adopted the Consumer Product Safety Commission public playground safety guidelines, and because of that, playgrounds are a lot safer than they used to be. The two pictures at the top show two different playgrounds that comply with these safety guidelines. The picture on the left, you have a mulch material that can absorb a lot of shock, and it's not appropriate for toddlers, again, because they would put the mulch in their mouths, but for any children older than toddlers, this would be considered a good playground. As you can see too, the slide is not made of metal, so it's not going to get as hot, and it's not going to have like sharp metal edges on it like some of the slides that I might have grown up with. So that's an example of a good, appropriate playground for children above toddler age. Over on the right, you have another playground. This one could be appropriate for basically all children, even toddlers, because it's made of a unitary shock-absorbing material that children cannot get into their mouths, but it's also very soft, very shock-absorbing. The bottom two pictures show playground equipment and setups that would no longer be considered acceptable in most states, cities, and municipalities. You can still find old playground equipment in some small towns here and there. This is some of the playground equipment that I grew up with, examples of it. On the bottom left, you see a seesaw or teeter-totter. These things were fall injuries just waiting to happen. Not just fall injuries, but crutch injuries, because children would often get their hands and arms caught in the fulcrum that this seesaw teeters on. You would also have instances where a kid would bail out on the seesaw and send their friend on the other side crashing down, or they would try to come down really hard and sort of send their friend launching off of it. Seesaws were basically they were a lot of trouble. They sent a lot of kids to emergency rooms. For the most part, you don't see them anymore in playgrounds. On the right's a merry-go-round, which you might still see merry-go-rounds periodically, but they won't have gravel and chat at the base of it like this one does. They would have soft, shock-absorbing materials underneath them. The playground I grew up in at my elementary school actually had a merry-go-round like this on a solid asphalt surface, so that if you lost your balance and fell off the merry-go-round, you were going to have to see the school nurse, probably have to go to the emergency room because you would probably break a bone. You certainly would get scraped up really bad. Merry-go-rounds can go very fast, so these are the types of things that are generally no longer considered acceptable and would be kind of hard to find in playgrounds in the U.S. anymore. When we look at risk factors for falls in children, one of the biggest risk factors is actually gender. Boys are twice as likely to die from a fall compared to girls. There are probably some cultural reasons for this, that our culture tends to encourage boys toward more aggressive types of play, more risk-taking in their behaviors, and that's just, the numbers bear this out, that those who identify as boys are twice as likely to die from a fall compared to those who identify as girls. We know that low socioeconomic status children that come from low SES households, are more likely to be injured from falls. This is partly due to not having as much supervision because they might have parents and caregivers who work a lot. And it might also be due to environmental deficiencies. There's more dangerous built environments for people that live in lower socioeconomic status regions. The playgrounds might not be as safe, might not be as updated. The schools might be a little bit more dangerous. The homes might be older. This is consistently seen over and over. The location for falls, most often it's in the home, though school and playground is a close second. Children suffer fall injuries from windows, from trees, from tree houses and balconies. Falls from playground equipment are also very common. Slides and climbing frames probably being the top ones. A lot of times children will climb up a slide and rather than sliding down it, they will fall or jump over the side of it, and that leads to a lot of injuries. And of course, climbing frames. Children love to get on those. They like to hang by bending their knee, folding their legs over the tops of the bars and then hanging upside down. But a lot of times they swing back and forth and then they fall off. Falls from shopping carts are another very common risk factor for falls in children, as are skateboarding and the use of trampolines. Some evidence-based approaches to prevent fall injuries in children include, we talked about this before, having playground surfaces that are more protective, either shock-absorbing unitary materials like you see in the upper right picture, or mulches, as you see in the picture below that one. Certainly, to avoid head injury when bicycling, children should always wear bicycle helmets. Many states have a law that you have to wear a bicycle helmet regardless of age, regardless of whether or not you're on a road. However, here in the state of Nevada, there's no law whatsoever to require bicycle helmets, even for children. But of course, sense and the Consumer Product Safety Commission and just general care would indicate that children should be wearing bicycle helmets every time. You should avoid putting children on high surfaces. Use safety belts when available. Use window bars or furniture, or keep the furniture away from windows, because this happens way too often where children will make their way up to a window, will crawl up into it. They don't necessarily have a sense of danger, and they will fall out the window. And if you're up above the first floor, that can be very rapidly fatal. Certainly other engineering controls for a house can include gates above stairwells, self-closing doors, locked cabinets so that children can't climb up them, and of course so they can't get in and be harmed by the contents of the cabinets either. Bed rails, improvements to porches and balconies to reduce the likelihood of children going through bars. Bath mats and slip-resistant surfaces. These are important for the elderly, but they're also very important for young children as well, who maybe don't have as much body control, or their attention might wander when they're in the bathtub. So it's important to have slip-resistant surfaces in there for children as well as the elderly. Most experts in safety very strongly recommend that you never use a baby walker. There was a time when these were used a lot to try to encourage young children that were learning to walk to sort of build up their lower body strength, help them to balance and be upright and kind of learn how to walk. You see a picture of one up here on the top. It's been found, though, that these cause a lot of injuries, and in fact, the American Academy of Pediatrics has called for a ban on the manufacture and sale of these little wheeled baby walkers like you see here. So, yeah, you can see how you can very easily have a child fall forward and hit their head on the handle of it. It's, let children sort of figure out how to walk on their own, be with them, sort of let them fall sometimes, but having an object like this that they can fall on as a training aid is not recommended. What's also not recommended is trampolines. The American Academy of Pediatrics also they don't believe that trampolines are appropriate for home use, inside or outside, for children. The American Academy of Pediatrics believes that trampolines have no place in outdoor playgrounds and that they shouldn't really be regarded as play equipment. They're really more of like an exercise equipment, and only for kids or for kids of an appropriate age or for adults who know what they're doing. And even for adults who know what they're doing, trampolines can be so dangerous. It's so easy to get slightly sideways on them and then hit the sides of them where it doesn't spring, where you don't spring back, and you get yourself injured. So that's the Falls lecture. Let me know if you have any questions or concerns. Thank you for your attention today.